walked into my clinic complaining of headaches, fatigue, and chest pain. Every physical test came back normal. What she actually had was depression, and nobody had ever given her permission to call it that. Day 27. And today I want to talk about a public health crisis that hides inside every other public health crisis: mental health. In Africa and in Brazil, we have built health systems that treat mental health as a footnote, an afterthought, a specialty for the wealthy or the severely ill. That decision is costing us more than we realize, and it is time we named it clearly. The scale of what we are ignoring. Let me give you the numbers that should alarm every health policymaker on both continents. Depression and anxiety disorders affect a substantial proportion of the global population, and low and middle income countries, including most of Africa and large parts of Brazil, carry a disproportionate share of that burden while receiving a disproportionately small share of mental health funding and infrastructure. In many African countries, the number of psychiatrists per population is staggeringly low. Some nations have only a handful of psychiatrists serving entire populations of tens of millions. In Brazil, despite the ambition of the SUS system, mental health services remain unevenly distributed, with rural and northeastern regions experiencing severe gaps in access compared to wealthier southern states. And here is what the numbers do not capture: the patient who presents with unexplained physical symptoms that are actually the body's expression of untreated psychological distress. The mother who is functioning, working, raising children, while silently carrying a depression that nobody has ever asked her about. The young man who dies by suicide in a community where mental health was never discussed, never screened for, never treated as a medical condition rather than a personal weakness. These are not edge cases. They are the daily, invisible reality inside primary care clinics across Africa and Brazil. Why mental health is inseparable from every other health outcome we care about. This is the argument I most need policymakers, funders, and fellow physicians to genuinely absorb. Mental health is not a separate category from physical health. It is the foundation underneath nearly every other health outcome we currently prioritize. Maternal health. Untreated postpartum depression affects bonding, breastfeeding, infant development, and a mother's own long-term health. Yet postpartum mental health screening remains inconsistent across both Africa and Brazil. Chronic disease management. A patient with depression is significantly less likely to adhere to diabetes or hypertension medication regimens. We treat the diabetes, we ignore the depression undermining the diabetes treatment. Child development. A child raised by a parent with untreated depression or anxiety experiences measurable impacts on emotional development, educational outcomes, and future mental health risk. Economic productivity. Untreated mental illness costs economies enormous sums in lost productivity, absenteeism, and disability. Costs that dwarf what it would have taken to fund adequate mental health services in the first place. You cannot build a healthy population, a healthy economy, or a healthy next generation while treating mental health as optional. What integration actually looks like practically. So what does taking mental health seriously actually require, beyond simply building more psychiatric hospitals that most communities will never access? Integration into primary care. Every direct primary care practice I envision for Africa includes basic mental health screening as a standard part of routine consultations, not a specialist referral that requires a separate, often inaccessible appointment. Depression and anxiety screening tools exist that any trained primary care physician or nurse can administer in minutes. Task shifting to trained community health workers. Just as community health workers can be trained to screen for hypertension and malnutrition, they can be trained to recognize warning signs of depression, anxiety, and suicide risk and connect families to appropriate support. This model has been successfully piloted in several African countries, proving that mental health support does not require a psychiatrist in every village. It requires a trained, trusted community presence. Faith community partnership. As I discussed earlier in this journey, faith leaders are often the first point of contact for someone in psychological distress. Equipping pastors and imams with basic mental health literacy, enough to recognize when prayer alone is insufficient and a referral is needed, could transform mental health access across both continents. Destigmatization as a clinical intervention. Public education that explicitly names depression, anxiety, and other conditions as treatable medical conditions, not as spiritual failure, personal weakness, or something to be hidden, is itself a form of public health intervention that costs relatively little and could save many lives. What I am committing to build into my own practice. I cannot solve the mental health infrastructure gap across Africa and Brazil through this channel alone. But I can be honest about what I am committing to build into MG Consultas and into the DPC network vision I have described throughout this journey. Every DPC practice in the network I am designing will include routine mental health screening as a non-negotiable standard of care, not an optional add-on. Every community health worker integrated into the model will receive basic mental health literacy training alongside their physical health training. Every faith community partnership will include mental health awareness as part of a formal collaboration, not an afterthought added later. And on this platform, I will continue speaking about mental health directly, by name, without euphemism, because the silence around mental illness in our communities is itself part of the public health problem. If you are a young person watching this and you are struggling quietly, invisibly, in a community that is never giving you permission to name it, I want you to hear this clearly. What you are experiencing is not a personal failure. It is not a spiritual weakness. It is a medical condition that deserves the same seriousness, the same treatment seeking, the same compassion as any physical illness you would never hesitate to see a doctor about. You deserve a health system that sees your whole self, mind and body together, not one that treats your mind as an afterthought. If this named something that needs to be said more loudly, share it with someone in your life who has never had permission to talk about their mental health openly. 2 days left. Day 28 tomorrow. The doctor my patients never see. What happens behind closed doors in a DPC practice? Subscribe. Comment below. Does mental health get discussed openly in your community? Or is it still silenced? I want to hear from every country in the comments. See you on day 28.